it is a pleasure to present on the behalf of a group of people, physicians, engineers, nurses, that helped to arrive at this point, at this very first data presentation regarding the Saturn device. The Saturn device is a device that has a unique mechanism where you have an annular ring that goes in the subannular groove, a central stented valve, but the big feature of this valve, differently from similar technologies, that the annular ring is interlocked to the central valve mechanism, so you can control the positioning of the valve. This gives you several advantages. First of all, you have an inverse remodeling of the base of the ventricle. In surgery, we have used undersized endodoroplasty for ages to reduce the mitral regurgitation in secondary mitral regurgitation. You have a low profile here. This is a left ventricle of a pig, which has a narrow LVOT. Despite that, we have full space since the valve depth is only 13 millimeter. And then this unique characteristic, jail the anterior leaflet. So if you treat a patient when there is the risk of SEM, this is not possible with this valve because the anterior connecting arm jail the anterior leaflet. This is the procedure. The transeptal puncture is performed in the usual way. We want to be coaxial to the mitral valve. At this stage, we introduce the guide wire delivery system, which is has two ports, one that goes below the posterior leaflet and one in the aorta. We do the first half loop, we snare it in the aorta, and we create the first annular segment. Then we create the second loop. At this stage, all the procedure is done as a consequence of steps. So we remove the guide wire delivery system and we connect the valve, central stented valve, to the annular segment previously deployed. And at this stage, we are able to really go to pull at the base of the ventricle and release the valve. So I'm here to present the first 12 patients treated all around Europe and Georgia and UK. This is the profile of the patient, so 71 years old, high risk for surgery with moderate to severe old patient or mitral regurgitation with a mean AF of 47%. This patient has also a pulmonary pressure of 49 millimeters. Another important data is regarding the annular perimeter. This patient has an annular perimeter of 131, meaning that you are treating a diameter of 42 millimeters, and we implanted a 28 millimeter valve, having a reverse remodeling of the base of the ventricle. We implanted successfully 11 patients. In one patient, we had a conversion to surgery, and it was a failure of one component at the initial part of our learning curve, and there was a failure of a wire that we now changed, and since then, we have never had a problem. We have only one patient that has vascular access bleeding, and it was again at the beginning of our learning curve. The procedural time of loop placement, for sure it has been the first 10 patients, it usually lasts for 53 minutes. All the patients, as you can see, at 1 year, there are no mitral regurgitation. What are the main findings of this valve? Since we have maybe this remodeling of the base of the ventricle, we have a stable left ventricular ejection fraction. So we are not having a drop down in the ejection fraction after valve placement. And also it seems a data towards left ventricular reverse remodeling that we said maybe it's a good thing for our patient. Again, the stroke volume increased, and we think that stroke volume is the one is more important parameter to look at rather than other parameters. All the patients experienced better quality of life as assessed by Kansas City Living Questionnaire and 6-minute working test. If someone thinks that this is a complex procedure, this is our device, and which is similar to other devices already in the market that has been used for in thousands and thousands of patients. So to position the device in the center of the valve is not a problem. This is the positioning of the device after rapid pacing, and this is on fluoroscopy. Again, the feature of this valve, really important. We treated a patient with a prolapse of the anterior leaflet that could impede the flow in systole. And as you can see here, the anterior leaflet is entrapped and jailed by the valve, so no SEM possible. This is an explant in preclinical work in an animal, and you can see what I'm saying. And again, no LVOT gradient in all the patients that we have treated. This is a final result of a patient with partial MAC. And this is how the valve behaves under human, in a human heart. You can see here that the valve is moving with the muscle, which is really important maybe in patients that have an impaired ventricular function. Again, this is not supported from data, but as you can see here, the valve moves. Said that, we presented the first 12 transeptal patients in the Cassini-U study, and a parallel study in the US will begin soon. We demonstrated that there is a reproducible implantability with a reduction or elimination of MR with a favorable safety profile. Again, this elimination of MR has an impact on functional state of our patient, as declared by 6-minute working test and NYH classification. Thank you very much.
Any questions from the audience? If not, I mean, obviously the strategy is kind of the combining the best of both worlds to say, I mean, the annuloplasty and the valve replacement, but it obviously makes planning of the procedure quite complex, I would assume. Can you maybe elaborate on what's your screening for these procedures? What are the exclusion criteria, and what's the range of mitral annular diameters that you've been treated so far?
So in pigs we have, our range of diameter, the higher that we can treat is 140 millimeter of millimeter. Said that, we exclude at this stage a patient with diffuse prolapse of the leaflet. The patient treated with the anterior prolapse was a compassionate case, was not in the study. And the planning is really like the other. So we implanted the valve and we calculated the near LVOT, which as numbers, we stay on the safe side, and we want to have 200. And as soon as we have CT scan in comparison, we want to assess how our calculation is good to understand if we are over or underestimating. We have done now 2 CT scan, and it seems that we are underestimating the LVOT, which means that maybe we can go further, but still, this is a startup. There are 12 patients, so they are really pre-selected, I would say, to go well.
And how low can you go in terms of annular diameters?
No, that is, to be really honest, it's something that we didn't take into account, since we want to treat MEC in the second phase. So said that, there are similar technologies that treat MEC, and so I think that...
A quick comment. We have recently shown that patients with a bigger annulus may have worse outcome due to maladduction. And I think the big difference is if you implant a tendon, for example, or a valve which is fixed by expansion, you hinder the ventricle to get smaller and adapt to the new volume load, whereas your system allows, as surgical valves do, to have a shrinkage of the annulus and to improve the remodeling process. I think that's a crucial difference between the devices. The fixation mode is the fixation mode having a force bringing the ventricle together, or is the fixation mode holding the ventricle apart? I think that's a very new concept. Thank you.
No, thank you for your comment. Thank you very much.